Chris, how did you sign off on your own stuff? How did you sign off on your own stuff?
I just put in the ID, so I get to later.
Oh, you signed it. Signed off on something.
I didn't know what he was talking about. It wasn't me. Everybody's not yours.
What did you say?
The big butterfly?
I don't know what that is.
It's got wings on it like a butterfly.
Dr. Baby's looking at you actually right now.
That's an interesting animal. Insect.
What's that?
Yes.
Wait, Alec, there's something wrong with you. No, it's not.
That's like classic, embarrassing drunk night tattoo.
So apparently you must have one because I've never even.
Yeah.
All right, I'm gonna go to the list.
All right, go it down.
All right.
You're gonna get flagged for most of
I know, right?
Did you find a slide?
I see it.
I know. You know, Hey, for the first domino in class. Like, see, I'm coming. You guys are ready. You guys can eat a ring. They're looking for the slide, so.
We're looking for this slide?
Yeah, we don't have it.
Really? Spinal trauma? Yeah, it's under miscellaneous. He's what? Oh, he's emailing it out? All right.
And we are good to go.
All right, you guys ready? Ready for a little spinal trauma? If you finished your conversation about dick butterflies. Very, very small bits.
We can say that. I got your initial evidence. I had to do research.
Oh, yeah?
I didn't know what they were. Early today.
Can you guys tell me when I can start recording? Because I,
You were supposed to start a while back. I don't have to start over again.
I want nothing to do with that.
All right. So with spinal trauma, we're going to talk about anatomy and physiology, pathophysiology, and then the assessment and management of these kind of injuries. So annually, 15,000 permanent spinal cord injuries. Again, men, young, stupid men, out there getting paralyzed. Most of them are vehicle crashes. You have falls, penetrating trauma, sports injuries. 25% all occur, or 25% happen after the injury by improper handling of the patient. And so it's important to assume, based on mechanism of action, right? The patient could have spinal injury and appropriately treat them for it. So all spinal injuries you need to manage immediately, or stabilize immediately. For a spinal cord victim, and this is an old number, but lifelong care for a spinal victim exceeds $1 million. So that's a lot of resources. So best form of care is obviously prevention. I had a patient last year, 2 kids, drunk with his brother. He was like 32, thought it was a good idea to climb a tree, and fell about 40 feet. He had a complete transection of his cervical spine at about C6. I shouldn't say complete transection. He had a little bit of posterior cord left because he was able to feel on the backs of his arms on both sides, but couldn't move anything. And just a stupid night, right? Bad decision. Poor kids. So 33 bones in the spine. Obviously, it's structural support, major portion of the axial skeleton, and then the spine acts as a container of protection for the spinal cord. The vertebral body, which is the most anterior portion of a vertebra, is the major weight-bearing component. So, starting at the top, the atlas is C1. Now, this is a vulnerable vertebrae because it does not have a vertebral body. It's not extremely thick. This is what enables rotation of the head. So with any kind of axial loading accident, the atlas is always very vulnerable and has to be looked at very carefully. Both the atlas and then C2 is the axis. The axis contains the dens that goes up through the atlas and acts as a pivot for the rotation of the head. The cervical vertebrae have some smaller vertebral bodies. They have very prominent spinous processes, as you can feel on the back of your neck. All those bumps and spinous processes, you can feel those in your back as well. But as you're going down, obviously you're getting to the lumbar, very thick, strong vertebral body where most of your weight support is. And your spinal cord runs through the spinal foramen all the way up. So size of the vertebrae, like we talked about before, C1 and C2, the atlas and the axis don't have a vertebral body. They allow for rotation of the head. And of course, the vertebral body size increases as you go down. Lumbar spine has the biggest and strongest. Sacral and coxal vertebrae are all fused. They do not have vertebral bodies. The contents, so we'll talk about a little bit of the anatomy. You guys know spinal canal opening, the pedicles, right here and here, thick bony structures that connect the transverse process to the body. The laminae connect the pedicle to the spinal process, and then you've got transverse processes coming out the sides. They articulate with the ribs right there with those facets. And then you have the spinous process. Of course, only the thoracic vertebrae have the facets articulating with the ribs. This is more of a 3D kind of view of the spine. It's obviously coming out the back. This is coming out the front towards the abdomen, and the spinal cord runs right here. The disc is kind of a cartilaginous cushion in between the vertebrae. It's a shock absorber, but it does have a fluid matrix inside. So if you get too much pressure, axial loading, incorrect positioning, lifting heavy weights or whatnot, you can blow out that disc and herniate. When you get pain from herniation is when, mostly because you have forward flexion and lifting something heavy, or forward flexion in your improper positioning. So you get pressure that flexes down here, pushes the herniation out the back, and it pushes on the spinal cord. And that's why you get sciatica and different back pains like that, because the discs are pushing against those nerves. Vertebral ligaments. These ones are easy to remember just because of the anatomy. Anterior longitudinal ligament, obviously most anterior. Posterior longitudinal ligament, then you have the supraspinous, interspinous. You guys don't have to memorize those ligaments. They're just good to know from an injury standpoint because especially in the cervical spine, you don't necessarily have to fracture bones for that neck to be unstable. If you tear through ligaments, regardless of whether the bones are broken or not, that you can be have an unstable neck and require a cervical collar or eventually possibly a halo. So always look at that mechanism of action and suspect possible spine injuries. Cervical spine has 7 vertebrae. We talked about the atlas supports the head and rotates off of these facets. The dens goes through it right here, or I should say C2, or the axis sits under here, and the dens goes through and up the atlas and is the pivot for rotation of the head. That dens is also called the odontoid process. The cervical, or C7, has the most prominent spinal process. You can feel that in the back of your neck. It's kind of that big bump. Sometimes if you get too kyphotic, you'll see that hunched over look, and then you get that almost humpback, and you always see that spinous process poking out. That's the most prominent one. Thoracic spine has 12. The first rib articulates with T1, and they attach the transverse processes like we talked about before, the facets of those vertebrae. And then, we talked about the rib attachments of those adjacent vertebral bodies as you're going down the spine. The thoracic spine is obviously larger and stronger than the cervical spine, and lumbar is larger and stronger still. So you have stronger muscles in your paraspinal muscles to ensure that that body stays erect. And that's why oftentimes, well, not oftentimes, anybody with back injuries, physical therapies can be your most effective mode of treatment going forward. Because if you can strengthen up those muscles to support those joints, then you don't have that compression. Much more effective than any kind of surgical technique on the spine. Surgery on the spine is a last-ditch effort and 50% effective. Very poor statistic for surgery. But the problem is that physical therapy takes discipline. And you have to be very motivated in order to have good outcomes, and not very many people are. Not in this country anyway. They just want the quick fix, right? Lumbar spine, 5 of them. They bear the forces of bending, lifting above the pelvis, largest and thickest, and that's where the lumbar and the sacral plexus come off to innervate pelvic and lower extremity. Sacral spine is fused. As well as the coccyx. Coccyx is a remnant of a tail. You don't have to know all of the details of the anatomy of that sacrum. Just know that the sacrum attaches to the pelvis and is fused. Blood supply to the spinal cord. There are paired spinal arteries, branch off the vertebral, and of course cervical, thoracic, lumbar arteries, travel through the intervertebral foramina, and they split into anterior and posterior arteries. That's important to know for certain kinds of injuries, because if you injure the blood supply, how does that affect the spinal cord, and what symptoms does the patient obtain because of that? We'll talk about that a little bit later. So this is just more of the blood supply. You don't have to memorize all of these different connections. just know that they're paired and they split into the anterior and posterior to innervate the or feed the spinal cord. This is what transection of the spinal cord looks like at the different levels. The cervical cord, then you've got the dorsal root ganglion, and you have dorsal root ganglion all the way down to it's only drawn here in the cervical portion. It's important to know the anatomy here to understand why and how somebody has certain symptoms, and if they have those symptoms, what part of that spinal cord is injured. In general, your sensation is going to be more posterior, and motor function is going to be more anterior. On those, it goes into more detail, but you guys don't need to necessarily know all the details of those nerve roots. Anterior is motor. It's more motor. Posterior is more sensory in general. And it kind of branches off into fine touch, pain receptors, temperature, and all of those kind of things. We'll talk about that when we talk a little bit about some of the more common injuries in the spinal cord. So cervical spine, this is your phrenic nerve, controls the diaphragm. I mean, you guys know the saying, right? 3, 4, and 5, keep the diaphragm alive. That's where you get innervation through the diaphragm. So if you've got a cord transection above that, the patient can't breathe. And it has to be on a respiratory machine for the rest of their life. The lower C5 to C8 is responsible for a whole lot of nerves, but this is the brachial plexus. Axillary nerve, radial nerve, median nerve, musculocutaneous ulnar nerve. And so brachial plexus coming from C5 to C8 is all of your upper extremity function. Lumbar, T12 to L4. This is the lumbar plexus. This is extension of the knee, flexion of the hip. All right. That one's important to remember, just because there's so many lumbar injuries. So remember the lumbar plexus in differentiating from the sacral plexus. Lumbar plexus is extension of the knee, flexion of the hip. All right. And then the sacral plexus is more other lower extremity uses in the foot, ankle, and so forth. Dermatomes. Dermatomes is for sensation, not motor. All right. So when you're looking at the dermatomes, this is for sensation, and it doesn't always match up with motor because your motor nerves are interwoven. All right. For example, C7. If you look at C7, that's all the back of the arm, right? So you would expect C7 to control triceps, but both C6 and C8 also will help with triceps. So if you take out one, you'll still have compensatory factors when it comes to motor. Sensation is different. Sensation is very direct, and that's why we have these dermatomes drawn out. Because as you're doing an exam, and do you feel this? Do you feel that? Do you feel this? You can figure out exactly where that transection is and where the injury is in the spine by using those dermatomes. And I think on your guys' slide, they have the little finger incorrect. Is anybody looking at your slide? What does it say the little finger is?
So,
It does say C7? Okay. Then he used my slide because I think I changed that one. But it's important to know umbilicus. These are kind of big ones that give you a starting point in figuring out the dermatomes. Collar region is at C4. Your little finger is at C7. Oh shoot, actually, let me see. Change that, but it's not changed. Little finger is C8. It's 6, 7, 8. 7 is the back of your arm and goes to the middle finger. 6 is your thumb and index finger, and then little finger and ring finger is going to be C8, not C7. So that is wrong. Nipple line is at T4, your umbilicus is at T10, and then your small toe is down there at S1. Your sacral is the backs of the legs. When people have sciatica and they say they're getting shooting pains, you can usually find or follow those dermatomes. If they have an L4, L5 disc herniation, you'll find that they'll say, oh, I get this pain that comes down around my butt and it kind of wraps around my leg where my knee is and then goes down the inside of my leg. That's that L4, L5. And they have that pain that goes perfectly along that dermatome. This talks a little bit about the dura mater and pia mater, still wrapping around the spinal cord just like it does in the brain. It has CSF. When we do a lumbar puncture, we're tapping into the dura mater and trying to get CSF fluid in that space without causing any injury to the nerves. The epidural is lidocaine that you're getting on the outside of the dura. Actually, it would be on this side. Oh, you're right. Nope, it's on this side. Sorry. That would be where you get an epidural in between.
So where that's pretty high up and doing that epidural.
Generally, epidurals are done in the lumbar spine. You would do more local nerve blocks if you're going to do anything higher. So if you're going to do something for upper extremity, you usually block like at the axilla, but instead of at the spine. Lower extremity and lower abdomen do epidurals. Myotomes. Extension, I'm not sure. This, I don't know why. Maybe I didn't save my changes. But this should be more arm abduction is C5. So bringing this out, that's deltoid and axillary nerve that comes from C5. Because extension makes you think, I mean, that's just not the right word. It's more abduction than extension.
C5 is arm abduction.
Arm abduction, yeah. Elbow extension is C7. That's tricep. But you also get help from 6 and 8, which is the case in most myotomes. It doesn't solely come from one level, but these give you kind of a general idea. Knee extension, L3, ankle flexion, S1. And that's what we talked about, kind of matched up with some of those, essentially the S1 of the small toe, S1 also does that ankle flexion. This is kind of a complicated diagram. You don't have to memorize all of these, but it is interesting in trying to diagnose any kind of nerve injury or cord injury, and what's actually controlling what. Over the last year, I've learned more about brachial plexus injury than I ever thought I needed to. Reflex pathways. So this is reflex connections that bypass going to the brain. It doesn't need brain to tell those muscles what to do. It just goes to the spine, goes right back out, so that it's super fast. And this helps to reduce serious injury, helps to stabilize the body in certain instances. So for an example, touch a hot stove, it flexes, it's automatic reflex, feel that hot pressure, automatic reflex or reflex to pull away from it. And then on the opposite side, you'll get extension because that flexion sometimes will pull you off balance, so the other side will extend to try to maintain balance. And that'll happen with your legs as well. Example of stepping on a nail. On the ipsilateral side, it'll cause a reflex flexion, and then on the contralateral side, it'll tell your other leg to extend, make sure that you're maintaining balance and you don't fall over.
Is that why, kind of a weird question when I asked about this a bit, Marvin, the other day, is that why, like, if you're at the edge of the dock and like ready to fall in the water, you're going to catch your balance, you actually move forward? Is that kind of that same idea?
I don't know.
Yeah, like your body goes like direction you shouldn't be going.
It's a good question. I don't know.
How does that have to do with that? Never mind. Dumb question.
Might be. That might be a reflex. So subdivision of autonomic nervous system. We've talked about this before, where parasympathetic is also in the cervical and sacral, right? And thoracic lumbar is all sympathetic. So parasympathetic, what does it do? Slows the heart rate, increases digestion, plays a role in your gonads. Then the sympathetic is all thoracic and lumbar, and has connection with the adrenal medulla, is where you get a lot of catecholamines from. But major functions: vasoconstriction, releases epinephrine, norepinephrine. Systemic vascular resistance, because of that vasoconstriction, increases the heart rate, increases cardiac output. So how do we get these injuries? They hyperextension, hyperflexion, excessive rotation, and then those lateral injuries. Yeah.
Quick question about that. You're saying that those nerves actually don't even travel, the parasympathetic nerves that come from cranial nerves, they don't even travel down the spinal column?
There's no parasympathetic innervation in the thoracic or lumbar spine. They come from the cervical, but they do innervate different organs. Like heart, that's vagus, right? But you also get, that's cranial nerve 10, cranial nerve 9, cranial nerve 8. But they do have, vagus affects digestion. So you've got innervation all the way down into the pancreas, stomach.
You're talking about like neurogenic shock, you've got transected spinal cord, C7 or whatever. You have that thing going below that point. You still have all the parasympathetic nerves still being intact.
Yeah, parasympathetic is still intact.
Not going through spinal.
That's why in some cases, depending on how bad the injury is, that's why it's so important you do a rectal exam, because a patient might be totally paralyzed, but they still have rectal tone, and that's because they still have parasympathetic innervation. But that generally means that they didn't have a complete transection, but that on the very posterior side, that parasympathetic tracts was saved. All right. Axial stress, axial loading. So this is compression, right? You get axial loading from the top or from the bottom. Common compression fractures are in the lumbar spine. Old ladies fall on their butt, squish their vertebrae there. Other mechanism of injury, you've got direct, blunt, penetrating trauma, and then electrocution that can injure the spinal cord. So flexion injury, where you have severe flexion and then those anterior portions of the vertebral body slam together, they can cause wedge fractures. So if you get just a regular x-ray, you can see that wedge fracture. You know that there is possible ligamentous injury and possible spinal cord injury because those vertebrae were crushed together in that flexion incident. Axial loading, you get compression injuries. Then, of course, penetrating trauma that is just directly to the spinal cord. Hyperextension injury, just like whiplash and car crashes, create the opposite effect, is those flexion, where they get compression of the spinous, but can have obviously negative results on the spinal cord itself, depending on injury, edema, swelling, everything else. Then you've got your rotational injuries that cause a lot of tearing and disrupt the muscles. Distraction injuries is the opposite of the compression injury, where you are pulling and spreading. Let's see. It's important here. Just remember common sites of injuries: C1, C2, delicate. C7 is a transition from cervical to thorax. It's a common site of injury, especially in car accidents, whiplash. And then T12 to L1 is responsible for all your bending, lifting, and sites of all of your lower extremity nervous injuries like sciatica. You guys don't have to worry about those columns. So, cord injury. You can get a concussion of the cord just as well as you can get a concussion of the brain. It's temporary, but you have a temporary disruption of that function. It's commonly known as a stinger, where you might have complete weakness and loss of sensation in your arms or legs, but they come back within, 30 minutes or so. That's a concussion to the spinal cord. Contusion is bleeding into the spinal cord, and that can cause more tissue damage, and obviously has more swelling involved. So compression can come from a lot of different places. Bone compressing on the spinal cord, herniation from the disc onto the spinal cord, and then displacement, which is fractures, and then of course swelling of the adjacent tissues, like blunt trauma to the back, and just cause such significant edema in the area that it pushes on the spinal cord and takes away blood supply, affects everything from that site down. The laceration of a cord is usually caused by fractures that lacerate the spinal cord. Sometimes it can be direct penetration, like a knife stab wound or a gunshot wound. We talked about hemorrhage, but with all of those injuries, you can certainly, concussion, contusion, laceration, stretching, you're going to have hemorrhage, and you can create hematomas that cause a mass effect on the cord as well. Transection cord injury. So these are your different levels where complete cervical spine cord transection is going to cause quadriplegia. Quadriplegia is you can't move neither arms or legs, right? You'll be incontinent, and depending on where it's at, above 3, 4, and 5, especially if you're up there at 3 and 4, you'll have respiratory paralysis. Below T1, you'll have incontinence, but below T1, it'll be paraplegia, right? Because your cervical cord is what controls upper extremities, right? Brachial plexus. So anything below T1, you'll have paraplegia. So you can have cord injury all the way up here. At T1, you don't feel anything down. You can still move your arms just fine. And you can have incomplete transections, and that'll give you various symptoms. So know these. Central cord syndrome comes from hyperextension and tearing of certain blood vessels, but you get motor weakness affecting the upper extremities, and bladder dysfunction. Central cord syndrome is usually only happens in the cervical spine, and that's why it's upper extremities, because that's where you get your real extension injuries. And that can happen because of swelling and just site edema, but mostly because you're affecting the blood supply. When you have that severe extension, you're tearing those blood vessels, then you don't have any blood supply to the cord, and so you get injury to the central cord. Anterior cord, this is when you have loss of motor function, pain, touch, temperature, all below the site of injury, both sides. Okay, you can retain you retain position. You can feel vibration, and sometimes you can have some motor function with anterior cord syndrome, but it depends on how bad it was and how much of that anterior cord was injured. The more of the anterior cord, obviously, the more motor weakness you'll have. Brown-Sequard is something where it's caused by a penetrating injury and like a stab wound, and it only affects half of the cord. So if you take out half of the cord, what happens? It's because certain nerve tracts flip to the other side, right? And certain nerve tracts stay on that side from the brain stem and come out. So in Brown-Sequard, you'll have ipsilateral, which means on the same side as the injury, sensory and motor loss. And then on the other side, you won't feel pain or temperature. All right? Because pain and temperature don't cross over until they're at the level that they exit the cord. Does that make sense? Yep, ipsilateral is same side. Contralateral is opposite side of the injury or of the cord injury.
So with that contralateral, they still got their sensory and motor on the
Contralateral side.
sides that might still move it, but they don't have their.
But they can't feel pain or temperature.
So they like set their hand on the hot stove and not realize it.
Yep. Yep. It would. So, general signs and symptoms, obviously extremity paralysis is the big obvious one. But like we said, pain without or with and without movement. Even if they don't have weakness, they're having pain with and without movement in their spine. Obviously, you want to take those seriously. Tenderness along the spine. Impaired breathing, obviously for cervical injuries, priapism. So you take out the sympathetic drive because you have a cord transection, and they have priapism. They'd have to be drained with a needle. But of course they can't feel it. So what? Can be, yeah. Can be. So oftentimes they'll go in and take care of that parasympathetic innervation. But that's why somebody like Christopher Reeves, who was a quadriplegic cervical spine injury, could still have sex. Spinal shock. This is that temporary insult to the cord. Again, affects everything below that level of injury. The affected area, flaccid, no feeling, loss of movement. In these circumstances, you'll have loss of bowel and bladder control. Again, priapism, and then we talked about the hypotension from the vasodilation below that level. Neurogenic shock. And we've talked about this and why neurogenic shock causes the vasodilation below that. And you have the loss of the sympathetic tone. Dilation of the arteries, expand the vascular space, you get hypotension. You lose that sympathetic tone, you also have reduced cardiac preload, reduction of the strength of contraction. That's all that Frank Starling reflex, right? If you have hypotension, you don't have enough filling into the heart. If that heart muscle doesn't get stretched enough, it's not going to contract hard enough, right? So you get hypotension all around. We talked about all of that. talk about that too. You can have compartment syndrome in the spinal cord as well. Because you got swelling inside of a confined space, then that affects the blood supply and causes injury to the spinal cord.
On neurogenic shock, that does the body after a few weeks, or so it does kind of start to people out.
You mean like from a blood pressure perspective? The kidneys will start to figure it out, and it'll get better. Oftentimes, patients have to be on certain kind of medications to help with the vasoconstriction, depending on how much they can compensate for. So always, 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 right? Mechanism of action. Consider spine clearance protocol. Always consider stabilizing, immobilizing spine. Be suspicious with sports injuries. If you're unclear of the mechanism of action, if there's any kind of question, just use spinal precautions. Primary assessment, again, spinal clearance, spinal precautions. If there's a head injury, assume there's a neck injury. Intoxicated patients, any injury above the shoulder. Distracting injuries. Patient has a big femur fracture, and they can only feel the femur fracture, and they're looking at the femur because it's deformed, but they could still have a cervical spine fracture, right? If they were in something traumatic enough to break their femur, there's a chance that they could have a cervical spine fracture, and they just don't know it because they're distracted by their femur, right? That can happen with medical personnel as well. They get distracted by the big, cool deformity and forget about the other deformity that can paralyze them. So again, primary assessment, ABCs. Remember that suction. Maintaining, as you can see, it's always more difficult to intubate a patient when you've got your partner trying to stay out of your way, but maintaining C-spine precautions. You've got a lot of arms in the way, shoulder to shoulder. It's a little bit more difficult to try to get that airway in place, especially if they have any kind of facial injuries and they're bleeding all over the place. They're slippery, they're gurgling. It can be quite a stressful situation. So the rapid trauma assessment, you guys have your lecture with that. But always suspect in multi-system trauma, spinal cord injury. Evaluate the neck, deformity, pain, crepitus, warmth, tenderness at the neck, bilateral extremities. You're checking for flexion, extension, grip function, and then motor and sensory function. You're looking at their dermatomes. If they say, I can't feel my legs, then you're going up the body until you find out where they can feel, and then you can figure out where that cord injury is, right? And you know where to make sure that you pay attention. Babinski sign, what's the Babinski sign? Scrape along the sole. What should be a normal reflex when you scrape? Right, purling.
Yeah.
Abnormal. So if you have a cord injury and you don't have that reflex, you may flare those toes, right? Good. There it is right there. Vital signs, obviously part of that secondary assessment. Pulse, blood pressure, respirations, reassessment. You're always rechecking, especially with any kind of nervous system injury. You're always rechecking vital signs. Why is it important to recheck vital signs, or I should say specifically recheck, say, heart rate and blood pressure? Looking for a trend, all right? That's an important aspect for recheck vital signs to make sure that there's no trend, or be able to recognize a trend if present. This chart is kind of busy, but it's just kind of a good reminder of going down in your mind that assessment for spinal precautions. So stabilized. So this is protecting the spinal cord from possible further injury, right? to stabilize and immobilize is semantics, but they are different. Immobilize is to make sure that neck doesn't move. But that doesn't always mean that you stabilize it, because it depends on how you immobilize it, right? For an elderly patient, you immobilize them. Are you going to want something under their head or not? Yeah. Yeah, for an elderly patient, you usually want folded up blanket or something under their head, because they're not normally all the way down, right? If you put them all the way down, that hyperextends them, and that'll cause more injury. So, yeah, they talk about this spinal motion restriction, is that it's a description for modern spinal injury care. That's semantics. You guys don't even necessarily worry about the, that term there anyway. So spinal alignment is just basically putting them in a neutral position and immobilizing them. A position of function, right? So hips and knees should be slightly flexed. You put a rolled blanket under the knees. Always support the head and neck. Contraindications are if there's noticeable resistance, if they have increased pain when you're putting them into that neutral position, if they have neurologic deficits because of it, obviously that's not a good thing. And then gross deformity of the spine. You know, somebody that has significant curvature of their spine, you don't want to try to stick them into a neutral position and correct it in the ambulance, right? But the main message is that less movement is best. So what do you do with cervical immobilization case for a seated patient? Not laying down, seated in the car. How do you immobilize that spine? What's that?
Slide behind him. He's got a little bit of a backboard on it. Let's cover him. Then slowly taking out the backboard.
So that is basically an upper body backboard until you can get them onto a full spine board, correct? You usually have somebody behind the patient holding C-spine while you're trying to get everything in place. Good. So we talked about this. Adults usually need to be a little bit above the ground. Kids, you want to avoid flexion and leave them on the ground. All right. Cervical collar. Obviously, it does not completely prevent movement of the neck, right? You want to put it on as quickly as you can. I think for the most part, it's a reminder to the patient, if they're conscious, of course, that they need to not move, right? Collar needs to fit snugly. Obviously, never impede respirations. It's important with elderly because it's easy to hyperextend them, right? You guys ever done a standing takedown?
Once.
Tell me about
It's awkward.
it. What'd you do?
So we did is a patient was standing up and cervical spine injuries, things like that. So we grabbed border ears, grabbed border ear, and hand over the head, and then you kind of grab, make it some butt your size too. Then you slowly lower them down. Someone's at the top of the board, and you go to come down. And you're holding spinal control all the way down. And then that person at the top takes over and you switch out.
So what was the injury? You guys needed to take those precautions.
It was an NBC.
And they were just up walking around?
Yeah, walking around, and then they started saying, you know, I have spinal pain, back pain, and so, you know, we told them to stop where they are.
Right.
It was a long time ago.
Yeah. It happens, and those are difficult, right? And for the most part, you want a lot of help with it. Don't try to do it maybe with just you and your partner. Oftentimes, those kind of scenes, you're going to have fire with you, all sorts of different personnel. So try to get as many people with you on that. And important to communicate with the patient exactly what you're doing so they can help you and not impede success. Helmet removal. You guys ever have any challenges with trying to get those helmets off? It's a pain in the butt, right? What do you do? Motorcycle helmet. Strap them in place with the helmet on. Yeah, obviously that would depend on the patient. I would say most of the time you don't want to do that just because you want quick access to the airway at any time, right? And the helmet would impede that. Because like what we talked about before, like a motorcycle accident, those are generally bad. And if a patient has progressing DAI, initially they're fine, cooperative, talking to you, tell you what happened, but they can go downhill pretty quick with a DAI, right? So you do want to get the helmet off. So a technique, obviously, two rescuers communicate with each other, have a plan. Don't try to pull the helmet off if the chin strap is still attached. Have one of your partners try to get under that helmet, immobilize the head, and do it as slow and gentle as you can in getting that helmet off. All right. So anytime you're working with the spine, all movements must be coordinated. There has to be really good communication with your team. You guys are going to be the medics, so you guys need to be vocal, right? Move the patient as a unit. No lateral pushing. The medic is usually at the head controlling the C-spine, and they're giving all the orders. Every movement comes from that guy who's holding C-spine, right? Nobody else is saying where that patient is going or moving. Only the guy at the head that is actually holding that C-spine is leading and giving orders to the rest of the team. You guys are familiar with all of this stuff, but way more familiar than I am. Rapid extrication. Those ones are tough, right? And those rapid extrications, you don't have time to get the kit out or whatnot, fire in the car or whatever. What do you do there? Have any of you guys had to do anything like that? Been in a case like that? What happened?
So the raceway guy crashes. I don't know exactly what racing model was, but 110 miles an hour and flipped long ways. And basically, we tried to extricate before making that decision, but he didn't make it. Probably wasn't going to make it anyways, but probably would have tried it a lot earlier in retrospect, actually, to just get it out there.
So initially, there was a little bit of thought of how we're going to do this safely, and
Right.
and in retrospect, you wish you would have just gotten them out quicker. Interesting. Happened with yours?
Mine was patient crew about 70, 75, ended up running into the back of a tow truck, ripped out he hit front on, and he spun and flipped the car once, and we got up there, he had a pulse, he kind of barely talking, and all of a sudden he arrested on us. So we kicked down the back of the back seat, blew the back window out, shoved the backboard in, and pulled him out of the passenger chair. And just went in.
Oh, you got a backboard in there?
Yeah.
Sometimes a backboard will make it easier to get them out than
He was a big boy.
not having it. Yeah.
So we were good to it.
Right. All right, so we talked about steroids before. You guys don't have steroids on your units anyway, and that is becoming less and less used, but traditionally has been a part of spinal cord injuries and trying to get steroids on the patient quickly. So medications with neurogenic shock, fluid boluses. It's not a volume problem, right? it's a dilation problem, but you can still help that dilation by giving them fluids. So that 20 mils per kg. Let's see, dopamine is always very effective with these kind of patients. And you'll find that true neurogenic shock, you only need a tiny bit of dopamine. You'll start them on 2 mics and boom, their blood pressure will correct. Atropine helps with the what? The heart rate, yeah, the bradycardia, all from that Cushing's reflex. So you guys don't have Demerol, and you guys don't use Valium either, but Versed obviously can be used to help combat a patient. If they are detrimental to their own injury and confused because they have brain swelling and everything else, then sedation is in their best interest, right? And sometimes sedation to intubation is required in these patients, even if they can secure their own airway. They're at risk for causing their own paralysis. All right, we're done with that lecture. Let's take a couple minutes and go get a drink, go to the bathroom, stretch, and we can get this thing done.
What do we got next?
We've got hemorrhage and shock. The hemorrhage and shock, there's 2 of them. It should be hemorrhage and shock, not shock and hemorrhage.
We do about 2 months ago, we had this one. Wrap it out with this guy. That was his car. Car was that one.
Oh, damn.
And then that's his leg when we got him out.
Oh, are you serious? Completely dissipated to me. Wow.
And then the hospital.
That is impressive. That's at the hospital?
And then put it straight down.
Yeah.
The only thing they pointed out was that just
Skin.
portion of his hamstring area.
I'm surprised that his lower leg actually looks as good as it does. His color looks pretty good.
The only thing that he had wrong with him was a fracture right there. And his last week's
That was it?
I did on a flatbed semi at 85. Tried to cut it.
Yeah.
And the flatbed semi thought he was going to curb and kept going.
Serious?
The dash came in and took his leg off.
Oh my gosh. Oh, I should probably stop that.
I'll take care of it.
Sorry.
Oh, no, you're good.